Good morning, everybody. My name is Karn Cliffe. I'm a Director of Nursing and Midwifery with the Dublin Midlands Hospital Group in Ireland. I have been involved with the National Sepsis Programme since its inception in 2016. I'm very pleased to be welcoming everybody here this morning across our worldwide audience, and of course our speakers. We've got some excellent speakers coming up. First off, I'd like to thank our sponsors for this entire session, specifically, and yesterday and today as well. First off, I'll introduce Dr. Yaseen Arabi. Dr. Arabi obtained his internal medicine training when he was a chief, he was a chief medical resident at Wayne State University, Detroit, USA. He obtained pulmonary and critical care training at the University of Wisconsin-Madison, USA. He is currently the chairman of the Intensive Care Department, the medical director, respiratory services, and professor King Saud bin Abdulaziz University for Health Sciences, King Abdullah International Medical Research Center. He's currently the principal investigator, co-investigator in several multi-center randomized controlled trials. He has been involved in MERS and COVID-19 research. He's over 450 publications, including articles in leading medical journals. He's currently a section editor for intensive care medicine on editorial boards of several journals. He received multiple grants and awards, including the Barry A. Shapiro Memorial Award for Excellence in Critical Care Management, Society of Critical Care Medicine, USA, 2011. Dr. Arabi, a very good morning to you.
Good morning. Thank you very much for the kind introduction.
You're welcome.
So thank you for the opportunity to talk about the multidisciplinary approach in managing sepsis. So I'll give a 3-minute highlight. As we know, sepsis is a medical emergency. We like to think about how sepsis progress from infection, starting local infection, then progressing to sepsis, septic shock, and multi-organ failure and death. And I think the major opportunities for improvement in the care of sepsis rely on understanding where delays happen. The delay in recognition and delay in treatment are the key areas where we should be focusing. And studies have shown that each 1-hour delay of appropriate antibiotics, for example, is associated with an increase in mortality. Could be 8%, plus minus, but certainly delay in providing care is essential. Now, this is a study where we did failure mode effect analysis, trying to predict where failures can happen in managing sepsis. And there are 3 areas: recognition of patients with sepsis, referring patients with sepsis, and resuscitating patients with sepsis are the major high-level steps. And underneath this, there are small steps that probably differ slightly from one setting to the other. But without going through all these details here, I think one would quickly recognize that these steps are multidisciplinary. They involve physician, they involve nurse, they involve pharmacy, they involve the primary team, they could involve surgeons, they could involve radiologists, etc. And without addressing the multidisciplinary approach to sepsis, we would not be able to reach the ideal care for patients with sepsis. Few years ago, we developed a sepsis alert system in our electronic medical records, and patients who met the criteria for SIRS at that time would have the pop-up message that is shown on the upper left, where the team will see that the patient met these criteria and will call for a physician to see the patient. And what you could see on the right side, these run charts showed that the compliance on the upper panel, the compliance with the sepsis bundle at the time, was in 2015, was around 20% when we started. And soon after we implemented this, it increased to around 50%. But then we took it to a phase 2 of the intervention, where we had a multidisciplinary sepsis team that consisted of a nurse and a physician who are paged when the sepsis alert comes through. And by having this, the compliance increased to around 80% plus. And what's interesting in the bottom here is what happened to mortality. And you could see that the mortality was of the patient with sepsis who were referred to the intensive care department were running around 50%. But with these implementations, the mortality has dropped substantially to around 17%. Now, certainly part of this improvement was related to the early recognition intervention. There may be other reasons that maybe you are identifying some lighter cases or softer cases. I think that can happen, but there's no doubt that there is a process of care improved and there is a reduction of mortality. We went further, and we are now for like several years in what's called SCREEN project, where we developed electronic alert system based on the QSOFA, and this alert goes to the bedside nurse in the workflow, and to the primary medical team, and also to the charge nurse on a mobile device. And then the data is fed to a dashboard where people can see the performance of their units. And what we are hoping that the alert will prompt the medical and nursing team to assess the patient. At the end of the day, this is what matters, is getting physicians and nurses. And this is what happened in terms of, well, as we implement this team, and this is across 5 hospitals in Saudi Arabia that has shared the same electronic medical record. There's the acknowledgement time of the nurse. When see the alert, has to acknowledge that he or she have seen the alert. It dropped from around half an hour to few minutes, and some wards like in 2 minutes. So really brought the attention to the nurses. For the physicians, we started off with several hours until the physician acknowledged in the system that he assessed assessed the patient, and it dropped dramatically to around 1 hour. We like to make it even lower, but it really reduced. And in certain wards, like this particular ward, and this data is from the dashboard, it dropped so dramatic from 9 hours to less than 30 minutes, which is our target. So by using multidisciplinary and using IT solutions as well, it helps getting the multidisciplinary team to the bedside to assess the patient. And one last slide is to remind ourselves that, and as I am an ICU physician, and the literature of sepsis has focused a lot on the care of patients with sepsis in the ICU. And certainly we can improve the patients, the outcome patients by focusing on the care within the ICU. But I think that's not enough. I think we need to think about the pre-ICU setting, because early recognition and timely management and prevention, even prevention of patients from getting sepsis, would probably lead to even bigger improvements in care. Let's not also forget about post-ICU care. So it's not good that you spend so much effort and energy on taking care of the patient, and then he moves to the ward, and the care is not transitioned properly, no handover, etc. And then things go wrong because there was no continuity of care. Let's focus also on the transition of care, rehabilitation, and we're going to hear about this later in the session. But the care of sepsis should start much earlier, really in the community. Vaccination, patient information when they should seek care. We know our oncology colleagues do a very good job in this. When patients start to have fever, etc., they should seek attention, but we should do it for many patients at risk. And let's think about the community post-discharge. Again, rehabilitation post-discharge of septic patients. With this, I conclude, and thank you.
Thank you. We'll have you back for the panel discussion afterwards. Can I introduce Dr. Mirfin Mpundu, please? So Mirfin is Director of REACT Africa, a member of REACT's Global Leadership Team. He provides countries with technical assistance on national action plans development and implementation, including regional bodies, and works closely with the tripartite organizations and regional economic communities. His expertise of over 20 years includes pharmaceutical supply chain management, infectious disease, and antimicrobial resistance, global health security, global One Health, international health policy, and diplomacy. He's always on the lookout for new partnerships and collaborations and works hard to get antimicrobial resistance on the global and African agenda. He sits on several boards, including the Surveillance and Epidemiology of Drug Resistance Infections Consortium Board. He is a co-chair of the External Advisory Board of the Newton AMR Drug Discovery Programme and an honorary fellow at the University of KwaZulu-Natal in South Africa, among others. Good morning, Dr. Mirfin Mpundu.
Good morning, and thank you so much for the invitation. Thank you so much. I'll just continue on where actually my esteemed colleague left. Indeed, sepsis is a syndromic response to infection and is frequently a final common pathway to death from many infectious diseases. I primarily work in the Southern African in sub-Saharan African region, where we do have a very high burden of infectious diseases. And we know that CDC, for example, estimates that at least 30% of antibiotics are prescribed in outpatient settings are unnecessary and contributes to antimicrobial resistance. In most of the low and middle income countries where I work, you can be able to afford to buy antibiotics without a prescription, and you can get even infusions in places where they should not be administered. And so the clear facts actually make it clear that really a multifaceted approach and challenge is what we are dealing with. So overuse and misuse of antibiotics really is the major driver of antimicrobial resistance. So there is this dangerous relationship that demands that sepsis improvement programs and antimicrobial stewardship programs work hand in hand. And so really, a collaboration among clinical teams with the support of proven and integrated clinical surveillance care reduce care variation and costs while improving patient outcomes for these life-threatening concerns. There are primarily two main steps that we have to address. I think one is prevention of microbial transmissions that reduces the burden of using antibiotics, but also infections. And secondly, it's to prevent the progression and the evolving into sepsis. Some preventive mechanisms of infection really involves really effective hand hygiene practices, such as hand washing and safe preparation of food, improving really sanitation and water quality, but also availability and providing access to vaccines, and particularly to those that are at high risk, as well as appropriate nutrition, including breastfeeding of newborns. Prevention of infections in healthcare settings is key. Mainly, it relies on having a functional, infection prevention and control programs and teams, but also effective hygiene practices and precautions, including hand hygiene, along with others. Prevention of the evolution of sepsis in both community and healthcare settings requires appropriate antibiotic treatment of infections, including reassessment for optimization and prompt seeking on medical care. Why should we invest in antimicrobial stewardships in low and middle income countries? AMS and sepsis management are interdependent and complementary approaches to infection management is key, and effective AMS can help to reduce the incidence of sepsis, but also while effective management of sepsis requires appropriate antibiotic use and stewardship. The solutions of stewardship are not that complex, but they are a challenge in low and middle income countries. And there are so many challenges around really implementing stewardship programs. I'll just mention a few as a start. At the national level, lack of policies, a national framework of antimicrobial stewardship can be a challenge. Lack of professional institutional commitments, weak AMS governance structures, lack of treatment guidelines. I go to a lot of facilities in the African region and guidelines are not in place. At institutional level, lack of funding, poor awareness of AMS usefulness by staff. It is regarded as an additional responsibility, as not as the way we should treat actually patients. Lack of ITC infrastructure, no really committees that focus on stewardship, lack of staff, lack of leadership, but also weak and lack of diagnostic capacities, limited microbiology lab, stockouts of consumables, lack of human resources, really SOPs, quality assurance programs, but also lack of quality assured antimicrobials. It's very common that the 10 most common antibiotics are very, very basic. And we have more patients, unfortunately, in the African region and other LIMCs that are dying from lack of access than actually access itself. And so these are some of the areas where we really have to link actually sepsis and actually antimicrobial resistance and see how in addressing antimicrobial resistance we can actually prevent bad outcomes like sepsis. Thank you.
Thank you very much. That's very insightful talking. We'll keep going, Dr. Mpundu, if that's okay, and we'll come back to you for the panel discussion. So I'll introduce Dr. Amanda Harley now. Amanda is Queensland statewide paediatric sepsis clinical nurse consultant and the first in Australia. Amanda is the paediatric nursing representative on Queensland Sepsis Steering Committee, a member of the National Sepsis Clinical Reference Group, and the Australian Paediatric and Nursing Representative for Global Sepsis Alliance platform. Amanda has her master's in critical care, postgraduate qualification in education, and PhD. Her PhD investigated recognition and management of pediatric sepsis in the ED. Her current role has her involved in the development, implementation, education, and evaluation of a statewide pediatric sepsis pathway. Amanda was the study coordinator for pediatric sepsis randomized controlled trial RESPOND, investigating a flute-sparing algorithm. She has instigated a number of sepsis projects and is the recipient of multiple grants. Amanda is passionate about sepsis recognition and the roles nurses play. By undertaking clinical practice with research and quality improvement, she is encouraging others to do the same. Welcome, Amanda.
Thank you very much. Thank you for having me. Thank you for the invitation, and welcome to everyone online that's joined our session. Good evening and good morning, wherever you are. So this afternoon, I'm going to talk to you about the sepsis nurse, a voice to lead and transform care. Now, usually my first message is always, could this be sepsis? But tonight my message is a little bit different. Tonight my message is about empowerment, as when I reflect, this is one of the key elements for me as a clinical nurse involved in research as well as in quality improvement, and was a key ingredient to what can be really, really important. So when you ask yourself, what am I capable of? What change do I want to implement? This is the beauty of being a clinician, being a member of the multidisciplinary team, and being a nurse. You don't know where it's going to take you. It's a journey of curiosity and continual growth and development, and that's a really exciting role to be in. So leading and transforming care comes in many different shapes and sizes, and tonight I'm going to share with you some that are pertinent to sepsis nurses working within the multidisciplinary team. Now, gone are the days of medics versus nurses and these archaic hierarchies. I've always been very fortunate to work in a multidisciplinary team that provides and values each member, appreciates the differing role and the individual contributions they make. But what role does the nurse play in this? In the last 7 years, a lot has changed in sepsis research, and a lot has changed in the role of nurses towards sepsis recognition and management. So be empowered to lead, be empowered to trust your discipline, speak up and make a difference to your facility. Make it a priority and know that nurses bring a different set of skills to sepsis care. In fact, a lot of successful sepsis initiatives have come from nurses leading the way. In Queensland, we implemented a statewide pathway in the state of Queensland over in Australia, and it was across 14 mixed population emergency departments. The focus was on nursing empowerment to recognise and escalate patients with suspected sepsis early on in their journey, knowing this was an identified gap in practice and an area that really required improvement. The pathway aligned with our early warning system and provided a scaffold for raising the question, could this be sepsis? It was medical and nursing led, but each site had dedicated nurse champions where available that initiated, educated and evaluated implementation. So to improve knowledge and critical thinking skills, we really took education and flipped it on its head. We designed tailored education sessions throughout the state, aiming to really raise awareness and educate creatively to promote that engagement during and after the implementation. Nurses were the key people that were responsible for this. So with that being said, I ask you the question, what gives you the drive? What gives you the drive to attend these sessions? What gives you the drive for your professional development to want to improve the care that we deliver to our sepsis patients in whichever country that we're in? Identify that and lean into it. So I found an area I could make a real difference in, and since that moment, there's been several publications and grants awarded, and I really had a realisation that as nurses, we possess a wide range of skills, knowledge, and professional capacity. These are all the ways that nurses can lead and transform care. The nursing expertise and repertoires that nurses have has allowed for, in this case, to design contextually appropriate education that can be delivered across the state and the nation, and really to develop resources for sustainability, knowing that this is a long game and not a short game. There's a broad range of skills that have been developed that have been beneficial to frontline clinicians, including involvements in guideline, clinical care standard development, root cause analysis reviews, community awareness campaigns, and the development of a statewide website and online learning modules that are accessible wherever you are. So I'll leave you with this. Where will your journey take you? Our role is critical in the clinical setting, but it is also imperative that we advance our leadership capabilities in quality improvement and nurse research-led initiatives. You have a great opportunity to lead and transform care for patients with sepsis. So where will you go? Thank you.
Thanks, Amanda. We'll catch up with you again in the panel discussion. Thanks. Introducing Mr. Kawaldip, Sehmi, CEO, International Alliance of Patients Organization. Kawaldip is the Chief Executive Officer of the International Alliance of Patients Organization. He has an academic background in public health and law and has a passionate belief in improving access to services through digital health and justice services. As the Managing Director of the International Children's Legal Centre, he led a team of international lawyers improving the rights of the child, including right to health, by applying remote courts. He has also served as the Chief Executive Officer of an international mental health charity, specialising in niche mental health services, supporting young people and adults with complex mental health, personality disorder and substance misuse problems, access telehealth and digital mental health services. Kawaldip is a passionate advocate of the WHO's human rights-based approaches to health and strengthening of the institutional, legislative, policy, practice and standards framework. He believes this support is needed to achieve the health goals outlined in the Sustainable Development Goals 2030, specifically Sustainable Goal 3.8, to ensure universal health coverage for all. Welcome.
Good morning, everybody. Thank you.
Good morning.
Right. Thank you very much. I'm on. Yes, I'll start off by saying that the past 3 years has been spectacular, once in a lifetime experience for us all, in that this is a pandemic that we had never encountered in living memories, in the sense that, yes, we have heard of old things in ancient documents, but this is something in our lifetime. And I think that what has been taught to us that we cannot ignore infections, that we all thought infections were over and done with, and that we were all concentrating on NCDs. And I think this has brought back the focus that infections are here to stay. But also, I think it's given us a great room to look at patient safety, global patient safety. We are part of WHO, and we're really pushing forward the Global Patient Safety Action Plan on sepsis, in particular infections and hospital-acquired infections. And it's important for us to realize that this is a moment that we can transform our healthcare in ensuring that we become sepsis-free in a way. You know, if you've got people trained up to pick it up, diagnose it, and treat it, it would be great to have that in our under our belt. We are going towards universal health coverage 2030 shortly, I suppose, another 7 years or so, and we must be ready for that. Make sure that those things that we can take care of, you know, what I call that extra burden on healthcare, which is unnecessary. This is avoidable burden. Let's remove them, and that's where we come in. That taking sepsis out of our healthcare will require the whole of government, the whole of patient community, whole of industry, and maybe even much further than that. We're looking at the whole of society to work with us. That is not anybody, single person's problem, it's the whole of society's problem. Thank you.
Thanks very much. Again, we'll catch up with you in the panel discussion, if that's okay. So I'll introduce Dr. Mohammed Alatwi. Pardon my Irish brogue and the pronunciation if I got that wrong. Highly qualified and experienced physicist who has made significant contributions to the field of physical medicine and rehabilitation. He obtained his Bachelor of Medicine and Bachelor of Surgery from King Saud University in Riyadh, Saudi Arabia, and became board certified in physical medicine and rehabilitation in 2015. He later went on to complete a subspecialty in concussion and traumatic brain injury from the University of Toronto. Currently, Dr. Alatwi serves as the chairperson of the Physical Medicine and Rehabilitation Department at King Fahd Medical Centre and is the medical director of the Spasticity and Baclofen Pump Program at the Rehabilitation Hospital. Additionally, he serves as the director of the PM&R program in the Shared Training Committee sector, one of the Saudi Commission for Health Specialities. He's certified brain injury specialist trainer from the Academy of Certified Brain Injury Specialists and a member of the National Health Registry for People with Disabilities in Saudi Arabia, as well as the Canadian Association of Physical Medicine and Rehabilitation and the American Academy of Physical Medicine and Rehabilitation. Dr. Alatwi has played a key role in the establishment of a new acute intensive rehabilitation program for trauma patients in a tertiary center in Riyadh, Saudi Arabia. He has also published and participated in research related to brain injury, concussion, and disabilities. As a founding member of the Saudi Society of Physical Medicine and Rehabilitation, he is committed to advancing the field and improving the lives of patients. You're very welcome.
Thank you for the introduction and for inviting me today and to have this opportunity to talk about the early rehabilitation in sepsis and ICU patient. Actually, I will talk briefly about what the early rehab, what the benefit of early rehab in patient and what the effect of healthcare facility with the early rehabilitation. Okay, as a definition, actually, at the beginning, let's define the early rehab. There are multiple definitions in literature about the early rehab, but the common one is the early rehabilitation in ICU for sepsis, referred to the initiation of physical, occupational, and speech therapy intervention as soon as possible after patient admitted to ICU and stabilized by the medical team. As well, we have early mobilization, not only early rehab. Early mobilization is the application of physical activity as early, sometime in the 2nd or 5th day after the onset of the critical illness. why we are talking about the early rehab in ICU and sepsis, why we need early rehab. Actually, with the advance in medical care, more patients are surviving post-critical illness. For example, in the United States, more than 1.4 million survival critical illness, and most of those patients end up with long-term physical and cognitive impairment. As well, the sepsis affect more than 1.7 million people in the United States. In ICU, the patients stay in the bed for a time, and immobility can affect the patient system, including respiratory, cardiovascular, pulmonary, musculoskeletal. And some studies show that the muscle strength in healthy person can decrease by 1.3 to 3% for every day spent in the bed rest. And new studies suggest that 3% to 11% strength loss occur for every day in the bed in the ICU setting. Let's imagine this is sometimes the only view for patient in ICU, which affect the patient psychologically and can trigger the cognitive impairment as well, agitation, because that we are talking about the early rehab. The goals for early rehab in ICU and the sepsis mainly to promote functional recovery, decrease duration for mechanical ventilation, reduce the length of ICU and hospital stay, and improve the quality of life of patient after discharge as well. Just to know the difference between early and standard rehab intervention in ICU and for sepsis patient. The early intervention is the therapist reviewed chart for all patients, and it is therapist-driven PT-OT consult and patient seen directly after admission in ICU for assessment. And there is daily morning round with the medical team to discuss the medical stability and the therapy frequency 5 to 7 days per week. The standard rehab intervention is physician-driven PT-OT consult, and the therapy review only the patient chart who has received a referral, and they hold the PT-OT program if medically unstable as the per hospital criteria, and the therapy frequency is 1 to 3 times a week. What the difficulty and barrier for rehab and early rehab in sepsis and ICU patient? Actually, the ICU and sepsis patient have sometimes the medical situation, multiple line machine connected to the patient, and risk for complication, because that we need trained therapists, trained respiratory therapists, as well trained rehab team to deal with the patient. There is multiple study talking about early rehab in ICU and the benefit for sepsis patient. Example, one study done in Japan, and the conclusion stated that starting rehabilitation within 3 days of ICU admission was associated with the shorter duration in future hospitalization and lower healthcare costs. Other studies show that rehabilitation decreases the incidence of pulmonary complication if done by specialized physical therapy in ICU. Here as well, article from Journal of Acute Care Physical Therapy about the benefit of early intensive rehab for patients with sepsis, and the results show the improvement in length of stay, mobility, as well discharge disposition. Another article is bilateral randomized control trial about the early physical rehab in ICU patient, and the results show that early intervention by rehabilitation team can increase ventilator-free days, improve peripheral and respiratory strength, reduce length of ICU and hospital stay in the hospital. Here, I will talk about our experience. We started the program named Let's Walk in ICU for critically ill patients by physical therapy department in our rehabilitation hospital in King Fahd Medical City, and started in 2021. And we have a pathway for assessment and categorize the patient in 3 groups. The patient, if the patient medically stable, ambulatory patient, out of bed activity, as well bed activity. We educate and train 120 ICU nurses. As you know, the nurses is the cornerstone staff member or team member in ICU, and we trained all the nurses for safety transfer patient for mobilization program. And by Q4 in 2021, we have 100% training for respiratory therapists, as well nurses in ICU. Here is example, even we start our program for ECMO patient, we start to mobilize the patient in the ECMO machine, and we have a good result for our program. The result of our program rehab, we notice improving the functional outcome of early mobility group by more than 2 in ICU mobility scale between admission and before transfer out from ICU. As well, the average length of stay is decreased in the quarter 3 2021 by 0.5 day, and in quarter 2 2022 by 1.7 days. Just estimated cost reduction, if we consider the ICU bed cost is 14,000 Saudi riyal per day, the cost reduced by 2.8 million in quarter 1 by starting early rehabilitation program. In another tertiary center, we start acute intensive rehab for trauma patient as well critically ill patient, and we assign physiatrists in ICU and trauma team as well with the neurology and neurosurgery team. We did a great job by starting rehab early, and this is just our observational for trauma and ICU for acute intensive rehab program. The discharge destination 1 year before and after the program, the discharge destination to home was increased by from 24% to 64%. At the end, I would like just to show you this slide. Actually, this is a cake, well prepared, perfect ingredient, and mixed very well by all team member in ICU. But without the oven, we cannot get this result. And rehab make different. Thank you.
Thanks very much. I'll welcome all our speakers back again for the panel discussion. And there are a few questions come in. So the first question is for Mirfin. What is the impact of health facilities in lower middle income countries putting efforts into antimicrobial stewardship if there is no national regulation and registration of pharmacies, doctors, and prescribing?
Yeah, when we look at low and middle income countries, we have a tendency to bunch every country in there. But actually, even amongst the countries themselves, clinical practice is different. But the challenges that are faced by these countries are actually quite common. And so for example, some of the challenges that one is going to see in most of the major cities, including the capital cities, is that 1 in 3 hospitals is not going to have a steady, clean and safe running water. That's just what it is. And so, that becomes really a challenge if you really want to implement a good actually IPC program or prevent actually health associated I would say infections. The other common amongst so many of these hospitals has to do with the chronic stockouts of so many, basic and common antibiotics. That's quite common. When we look at and say that amongst all these problems, there are few institutions that are striving and are trying to implement actually stewardship programs, including IPC. But in a generic sense, there are a lot of challenges that even the ones trying are going to face. The structural ones, the lab issues, the issues of actually trained staff, the fact that you don't have agreed upon guidelines, and some of the guidelines that are being used are actually so old and not looking at the common evidence-based actual practice. Yeah, so these are the common challenges that you're going to see really across the LIMCs. But it's important to mention that even amongst them, there are some health institutions where these efforts are being tried, despite the challenges that the countries face.
Thanks, Mirfin. I have another question for you. There's actually a few questions coming in for yourself, so stay with us for now. So what are the specific roles and responsibilities of each team member in the multidisciplinary sepsis care team? How can healthcare facilities ensure that all team members receive appropriate training and education in sepsis care to optimize outcomes? Actually, that can be for anybody.
Yeah, that's another very good question. I think one needs to understand that the concept of working as clinical teams has not been a concept that, for example, in the African region is so common. So you will not see, clinical rounds that are done, with a doctor, with a nurse, a clinical pharmacist, a nutrition, an ID physician working together with a patient. That's that's something that you don't commonly see. It's and so in terms of actually working as a core team and as a multi-stakeholder actually team for patients, it's something that you don't see. And one other thing that is a challenge in most health institutions is that IPC and AMS are looked upon as added responsibilities for the nurse, the pharmacist. They are not looked upon as key as key actually components of good clinical care. They are looked upon, I'm being given more responsibilities that I have to do. So that makes it very challenging to actually work together. When you look at the decision making in terms of, what are the priorities that the hospitals actually need, some of these decisions are made by management without very little consultation with the clinical care and looking at recommendations that the clinical team are going to make. And so you find that these decisions then they don't take care, the necessary requirements that are critical to provide and prevent and promote very good clinical outcomes. Yeah, so these are some of the fundamentals, and some of the things that can be as disturbing as not having clinical guidelines that guide actually treatment, and chronic stockouts of antibiotics. So all these actually come together and makes it weak. Thank you.
Yeah, thanks. I think Kawaldip wanted to come in there as well.
Yes, I'm glad Mirfin has really started this conversation on whose responsibility is it in the end. And I refer everybody to look at the Global Patient Safety Action Plan, which WHO has produced. And part of that is sepsis control is the number 4 item on its list. And within that, they've clearly stated that, personally, it's everyone's responsibility. It's everybody's watch. But more particularly, the patient and the family engagement within these healthcare centers is very important. Plus, also within the training of health professionals and educations. I remember, I'm very proud to be here for that reason, that the World Health Assembly is coming up soon. I first met the team from the Global Sepsis Alliance at the World Health Assembly when the idea of establishing that resolution was only being thought. And I'm glad this journey has begun. And that stage we had said, bring in the families. And I remember at the 2018 World Health Assembly, we had got some excellent families there, especially the father with Rory's Law, who really inspired the WHO. nurses from Ireland, I've forgotten her name. If somebody could give her, I needed to send a thank you to her because she really was good. As a nurse and a patient, she really brought it forward. So yes, it's everybody's responsibility and
Yes,
everybody's
for
watch.
sure.
And
Yes.
let's put that message across at this World Health Assembly again, that it doesn't mean that it belongs to somebody else. It belongs to us.
Everybody. Yes, for
Can
sure.
I add to this?
Thanks. Yes,
Yeah.
please come in.
Yeah, so I agree with all the comments mentioned by my colleagues. I think there are key issues for the multidisciplinary approach. One is the engagement of all shareholders from the beginning of starting quality improvement project. We need to get the doctors, nurses, the primary doctors, ER nurses, everybody together on the table to understand what the issues that are particular to this place. Second is the leadership engagement. I think there's a lot of work we need to do to campaign for sepsis. So people understand that sepsis is really a major health threat, and it can be improved a lot by all of us working together. The third point I like to emphasize is using data. There is no stronger drive for people to change practice more than showing their data. I think giving a general statement will make some improvement for a short period, but sustainable change require that we provide data, and having some type of indicators doesn't have to be too complicated to the teams across the healthcare setting. Let's remember that sepsis can happen anywhere in the hospital. So it happens in emergency room, on the wards, in ICUs, medical wards, surgical wards, oncology wards. So we need to really raise the point that any person who's taking care of inpatients, and in fact outpatient as well, should have some basic understanding of what sepsis means. So being an orthopedic, you need to know when to call for help. You need to know the signs of early sepsis. Otherwise, getting a patient with sepsis with multi-organ failure to the ICU will not serve the purpose. We need to prevent this, and the best way to prevent morbidity from sepsis is to prevent patients from becoming critically ill. Really.
Yes, for sure. Yep. Amanda's question here for you. Was the sepsis nurse an initiative from the nurses themselves? How did you manage to create this new specialization?
That's a fantastic question. Where do we? I think in relation to my role, Chris, firstly I'll speak of. So essentially that was a statewide position that sits with children's health, but essentially it is an overarching role that helps individual hospital facilities with their implementation of pathways, a lot of sepsis education, and then a lot of sepsis research that came out of that pathway implementation. Also around, I obviously have quite a special interest in nurses and nurses' role and recognition. So we also did a study around knowledge translation of nurses, having previously perhaps had a little bit of arguably lower knowledge about sepsis and understanding on what it was and how we could get traction on that, to see after we implemented the pathway, did we actually get a translation to practice? So that came from that. Then from there, we were fortunate in Australia to have a clinical care standard released last year. And with that has come about the importance and the recommendation for facilities to have sepsis clinical care coordinators for both paediatric and adult patients. In Australia and in Queensland, our health system is quite individualised, although we do sit under a public sector. Individual health services, it's up to their executives, management, nurses, doctors to rally for that and say, this is a priority, this is a role that we actually need. Some hospitals are much more successful than others, and the same is said for the implementation of the pathway. So I think looking at, as we've said, data, looking at root cause analyses, we used a lot of the publications around and the WHO's priority around sepsis to try and rally some funding to say this is a priority. this really does affect pediatrics and adult patients. We really can do better. It is something, if we get on top of it early, we can really change outcomes for patients. So using a lot of that language was certainly grabbed a lot of traction for some health services, some not. COVID also happened, which put even more monetary budget constraints, but now coming out of the back end of that and the clinical care standard, we hope to hopefully get a lot of care coordinators in facilities that really can help patients with that continuity of care as well, and include discharge planning and family support after an event.
It's been like there's a well-established national sepsis program in Ireland now, but the challenge is convincing the policy makers and the purse holders that this is absolutely needed. Like you don't have to convince a nurse or a clinician, rather a physician or a surgeon. Like they're walking that walk every single day. Thanks so much, Amanda. Mirfin, another question for you. What is commonly available for treatment of carbapenem-resistant gram-negative bacilli in Africa? Clostin, for instance. Is any of the new beta-lactams available? For instance, ceftazidime, and are they needed at this point?
Thank you.
A couple of questions there.
Yeah. So I think the first question, the first one is that the sort of a number of those are actually quite out of stock in most of the countries. You would not be able to find the third and fourth generations. You will not be able to find even the reserve group of antibiotics in most of the countries. So what ends up really happening is that you have to use the common broad spectrum antibiotics that you have, even if when you are not sure that it is actually the pathogen I'm dealing with is not sensitive, but because you just don't have anything to use, you are going to use that. Where you can write a prescription and have the family go out and buy from a pharmacy and bring it in, that's one option that seems to work, but that is not an option that's going to work for every patient. So there are also very heartbreaking situations where that whatever you have within the hospital is not actually the pathogen you're dealing with is just not sensitive, and in those situations there's nothing that you can do as a clinician. You just have to cross your hands, and that the outcome that's going to come out of this is bad. And those are the most very difficult and extreme situations that we find ourselves in, and I've been in these moments in different countries where you just don't have any alternative, and there's nothing that you can do. Your hands are tied as a clinician at that point. And also the fact that when we looking at lab capacity, and you being prescribing, being guided by the evidence of us knowing that the pathogen we are dealing with is XYZ. A number of times we don't, because our labs are just not functional. And so it's very difficult for you to be able to treat like that. And, it's sad that, and this can, a number of these countries across, you see that in the private sector, you may be able to identify when you've got a good microbiology lab. But in public health institutions, that remains a larger challenge. And sometimes, by the time that you get the culture results, the patient is already gone. And so that's the reality that we deal with. And these are areas that I think as a global community, we need to really invest in. But I think for me, what is even just more disturbing is the fact that in 2023, we have tertiary hospitals running with no clean running water in an institution. At the height of COVID, I worked in institutions where we completely had no water. Wow. No hand sanitizers. And so, this actually makes our hospitals to be great incubators of the most pathogen infections that we can. And sometimes we let our patients die because we can't do anything for them.
Yep. Thanks very much. Kawaldip, did you want to come in here?
Yes. I'm glad this is being brought up. I am also the chair of the African Medicines Agency Treaty Alliance, which we formulated. And I think this is something we've been debating on that as well through the country, that really we need to look at how our hospitals are kept and how clean they are. But at the same time, we're also looking at something more important and critical at this stage, and that was AMR. We know there are new bugs coming up, and this means everybody's hospital will be affected. And sepsis from one of these guys seems like a nightmare scenario, and they're truly indicated as the next pandemic. We have to be aware, and that should bring in everybody again. If you need to have another bite at this cake on sepsis, then let's look at AMR and use that as a battering ram to get high-level political attention on this. I think for that we do need new antibiotics, which are the sort of fourth generation sort of things we wouldn't be able to sell, but we have to control. But at the same time, it gives us the cost burden that this could incur, and that brings everybody back to the table. So sepsis needs to be brought back.
For sure. Thank you. Another question on antibiotics. Multiple use of antibiotics and unexpected stoppages of antibiotics will affect the drug resistance or not. So will it affect the drug resistance or not?
Yeah, I'll take there's a double edged sword here. Not only that AMR shortages, but also fake drugs. Yeah. You've got substandard antibiotics running around in many health systems, and they creep in. You'll be amazed. Even now, I am here in London outside Twickenham. We found some had crept into our own health system despite we were so careful. So the supply chains get corrupted along the line, and that's very important. I'm part of Fight the Fakes. This is a international group that just got registered in Geneva 2 months ago. And we're really keen on this issue that sepsis and fake drugs are almost like back to back in some countries. It's very important to deal with this together.
Yep. Another question on antimicrobial stewardship. In the setting of patients with severe sepsis, when do we have to consider the use of mutant preventing dose of antibiotics rather than just MIC? Is that any variables that we need to seek first? Or are there any variables that we need to seek first?
Well, I think maybe let me start, and other colleagues actually can. So I think firstly, just to build on to what my colleague mentioned, I think one of the fundamental things we have to be clear about, and we have to be clear with patients, is that even when we use antibiotics optimally, any use of an antibiotic, presents an opportunity for a pathogen to find a way to survive, which makes it worse when we use less or when we are overusing. But even the most rational use is an opportunity. So I think that is the fundamental one, because, these pathogens are going to evolve. They'll find a way to survive. So even when we use them right, it's just worse when we use them wrongly and actually suboptimally. Yeah, but I think that, you know, in answering this question, I think what is important is that we have to have a correct diagnosis when the patient presents, and unfortunately, most of the treatments that's going to occur in low and middle income countries are going to be based on empiric therapy, and so, you know, it's not every patient that you're going to get any cultures or any blood tests for you to do that. But
Yes.
even where you have the ability of really doing the cultures, they have to be done at the right time. And we have to ensure that our health system is strong enough that, you know, within actually 72 hours or so, 3 days or so, we get the results. It's communicated to the clinician who prescribes. We get back on the drawing board and see, is the patient on the correct pathway of treatment or not? But the challenge that where you can't have the lab capacity that is required, we are always shooting in the dark, and that's where the challenges actually evolve. But even where we have the capabilities and capacities of being able to get the cultures very early, it's very important that one, that the cultures are taken correctly. Number two is that the test is done well. There isn't any cross-contamination, or number three is that the results are communicated in a timely manner and fashion to the clinician, who should look back and say, okay, are we treating, is this what we thought on day one we were treating? Otherwise, there will always be this sort of actually, breaks in our clinical care pathways.
Yes, for
Thank you.
sure. Yes. Another question for any of our panelists. For sepsis and antimicrobial stewardship campaign to be successful globally, do you think hospitals should have dedicated sepsis team and antimicrobial stewardship team working in coordination?
I can take that because I'm engaged with my hospital on the same kind of structure. It's very important that, yes, we do have patient and family engagement within this team. It's important the hospitals actually are what I call the gateway, both ways, meaning sepsis coming in, sepsis going out. So we can really control those. It's very important to have that. Absolutely agree with the question, totally.
Can I comment? I agree also about the discussion. Sometimes people may feel there's a tension between the AMR and sepsis. Sepsis try to focus on early empiric therapy, while AMR try to focus on the wise and focused use of antibiotics. But in reality, when the discussion between the two teams come together, I think they meet nicely, because appropriate treatment of antibiotic is one of the major goals of AMR. So I think these discussions are essential, and that there's no contradiction between the two improvement projects.
Yes, for sure. Yes, we've seen that in Ireland as well. In fact, when we first started the campaign, the sepsis campaign, there were concerns about increased use of inappropriate antibiotics, but we haven't actually seen that. It's been fairly static, and in some instances it's actually reduced. Yeah.
If I can just add as well, I think if you've got a guideline that obviously, there's clinical assessment that comes into play in an emergency room, you're going off a suspected source. I think building in then appropriate mechanisms for de-escalation will certainly help with those.
Yes, for sure. Yeah.
Appropriate, IV oral switch, appropriate step down, appropriate review with patients that are on antibiotics. Because it's all well and good as well at 24 hours to say no bacteremia, they never had sepsis, and we hear these things as well, but that also is not the case, and we can't look at it like that, because a clinician in the emergency room sees a patient that to them looks like they have organ dysfunction, that they have this suspected source, they require antibiotics, and that is completely appropriate at that time of assessment. But then the important part of that is then let's reassess and make sure we're doing appropriate measures when we have a little bit more clarity on. So those two teams work together.
Perfect. Yep. Do you think that antibiotic cycling rotation has any significant role in taming ARM, knowing that some bacteria will lose the resistant genes when the pressure is no longer there? And that's for any of the panel.
Can you repeat the question, please? I'm not sure.
Do you think that antibiotic cycling rotation has any significant role in taming AMR, knowing that some bacteria will lose the resistant genes when the pressure is no longer there?
Yeah.
So the antimicrobial resistance.
Yeah, maybe I can take a step on that one. So antibiotic recycling normally occurs in most times when patients or when mothers have not completed giving the course to a child, or an adult has not completed. And so when they come and have an infection that they think that the symptoms are similar to what they they saw before, so they will actually continue that, but they might also give another child, or they might also give another adult in the family, or a neighbor, or a friend. And so you do have that sort of actually recycling. That's why it's important to really understand, and that sometimes there's a bit of some debate among us medical folks that should a patient complete a course or not, and that's a debate sometimes that rages in the scientific world. But I think suffice to say, what is important and the message we should communicate is that I've prescribed this antibiotic for you for this particular condition, and what is given to you, has to be taken, whether it's within 3 days or 5 days. You have to complete your course. There shouldn't be anything that is left out, and you cannot use anything that you're leaving out, to another family member or friend, because every exposure to really an antibiotic, is an opportunity for that particular bacteria to start finding a way of survival. So I think that's what I would say about that. Thank you.
I think antibiotic cycling also has been studied in cluster randomized controlled trial, and did not show that it really affected the prevalence of MDROs in hospitals. So I think the focus should be rather on de-escalation, on short duration of antibiotic, appropriate diagnosis, source control. I think that's where the science stands at this point.
Yep. Can I ask Dr. Alatwi a question, and it's more on your expertise around brain injury. There's what we see in patients, and it's not necessarily on the rehabilitation, but it's on the early diagnosis and recognition. But what we see with patients with altered cognition, for instance, ID, it's difficult to pick up on subtle changes. What would your advice be for people with altered cognition, for instance, ID, or somebody with an acquired brain injury?
Okay, thank you.
Thank you.
Just a clarification about acquired brain injury and cognition impairment.
Yep. No, sometimes it can be quite difficult to pick up on the subtle changes in somebody with altered cognition in terms of early recognition of sepsis. So what would your advice be for that somebody with an altered cognition, like somebody affected with severe brain injury?
Actually, for recognize sign and symptoms sometime in generally a rehab patient for sepsis, not only brain injury, as well in the spinal cord injury patient. The symptoms is different, and usually we try to educate our team, like our resident physician who is dealing with the patient, about the different sign and symptom for rehab patient. Example, in spinal cord injury with complete paraplegia, with paraplegic patient, sometimes only the symptoms is increase in spasticity. And if we figure that symptoms, sometimes autonomic dysfunction is spinal cord injury, and brain injury is similar. Patient, he cannot complain sometimes about the his situation, but we educate the family. The family is the key or the cornerstone. Sometimes the patient and family in rehab, as well the multidisciplinary team, like even the physical therapy, occupational therapy, they are educated how to deal with the patient and how is the patient sometimes deteriorated in physical therapy gym because he has some type of infection. Even the infection in rehab, sometimes we have a patient, an example, using indwelling Foley catheter or CIC for a long time. We can deal with the patient, or sometimes we deal with the patient with let's say asymptomatic infection, but if he got an infection, really sometimes we need help from ID, from the other medical team. But to know the sign and symptoms usually is different in those patients, and need more education to the rehab team how to figure out this changes in our patient, like cognitively impaired patient, stroke or brain injury, as well as spinal cord injury, and sometimes other neuro patient like MS and others.
Yes, thanks so much. And of course, very important to listen to family, somebody who's not just recently acquired brain injury or altered cognition. It's really important to listen to the people that actually know our patients. Thank you so much. I'm going to wrap it up here now. Thanks so much to all our speakers. That was very interesting, very thought-provoking and insightful discussion from all the panelists. I just encourage people online to please visit the World Sepsis website, sign the World Sepsis Declaration if you've not done already, and follow us on Facebook, Twitter, Instagram, LinkedIn, and TikTok. And thanks again to all the speakers and, of course, our sponsors. And I hope everybody enjoys the other sessions for the rest of the day. Thank you so much.